Hi, my name is Naeem Soomro. I'm professor of urology at Newcastle, and I take this opportunity to thank SIU for asking me to provide current perspective for partial versus radical nephrectomy. To do or not to do, that is the question that remains for small kidney tumors. Should we be doing partial nephrectomy, or there's no benefit and we must go back to doing radical nephrectomy? And this question has been with us for the last 150 years. And as the techniques have evolved from open partial nephrectomy to laparoscopic partial nephrectomy to now robotic partial nephrectomy, we have to continue to ask these questions. Zerny in 1887 was the first one to describe partial nephrectomy for small kidney tumors. There was initial enthusiasm, which abated after bleeding, urinary fistulae, and death. Vermoutum in 1950 described partial nephrectomy for peripheral and encapsulated renal tumors. The first big publication came from Mayo Clinic, in which they compared 164 patients in each cohort retrospectively who had gone either partial versus total nephrectomy in their unit. They did not find any significant difference in overall survival or cancer-specific survival between the two groups. The chronic renal insufficiency was twice as high after radical nephrectomy versus partial nephrectomy. And the local recurrence after radical nephrectomy was only 0.8%, whereas after partial nephrectomy, it was 5.4%. There was an article by Andrew Novick, Cleveland Clinic Group, in 2002. They looked retrospectively in patients, 485 patients in their unit who had undergone nephron-sparing surgery. And they concluded that long-term survival in patients after partial nephrectomy was comparable to those who had undergone radical nephrectomy. The tumor recurrence in partial nephrectomy was between 3 to 6%. 5-year overall survival was 81%, and 5-year cancer-specific survival was 93%. Andrew Novick produced an article in BJUI in 2005, in which he described indication for partial nephrectomy as absolute in situation where there was only one kidney, relative in patient who had compromised renal function or other comorbidities, and elective in which there was a normal contralateral kidney and there was no comorbidities. He made a case in this article for partial nephrectomy, stating that the renal imaging had improved considerably. There was improved surgical techniques. Post-op care was much better than it was in Zerny's time. Renal replacement therapy was available. And he also noted that long-term cancer-specific survival data and cost-effective data for partial nephrectomy was comparable to radical nephrectomy. There was an article by Frank Becker in 2006, which looked at nephron-sparing surgery for tumors more than 4 centimeters, in which he noted that the complication in that group was 13%. The tumor recurrence was 5.8%. 5-year survival in that group was just under 95%. Up to 15-year survival was 86%, and cancer-specific survival in this group was 100%. During this time, the technique of laparoscopic partial nephrectomy has improved, and there was a comparison between 1,800 cases of laparoscopic and open partial nephrectomy, and it concluded that early experience with laparoscopic partial nephrectomy was promising, and it was associated with advantages of less operative time, decreased operative blood loss, and shorter hospital stay, and when applied to patients with a single renal tumor of 7 centimeter or less. It was noted, however, that laparoscopic partial nephrectomy was associated with additional post-operative morbidity compared to open partial nephrectomy. There was, however, equivalent functional and early oncological outcome. The only randomized trial comparing radical with partial nephrectomy was undertaken by Van Hoppel Group. It was an ERTC trial. Its main objective was to compare overall survival and time to progression between the two arms. It looked at tumors up to 5 centimeters. Sadly, it did not accrue to its target of 1,300. It was only able to accrue 541 patients, and it was stopped prematurely. One of the concerns were that there was 21% crossover between the partial nephrectomy to radical nephrectomy. That meant the patient who were initially randomized to have partial nephrectomy, 21% went on to have radical nephrectomy. So any results cannot be extrapolated within that group with such a high crossover rate. The other concerns were that the quality of life and renal function outcomes between the two groups were not assessed. So we are no better off even after that attempt at randomized study. There was a systematic review in 2012 by Aberdeen Group, which looked at oncological outcomes following surgical management of localized renal cancers. In its systematic review, they looked at 34 studies, 6 of which were RCTs. And it concluded that open radical nephrectomy and open partial nephrectomy showed similar cancer-specific and overall survival. It also noted that laparoscopic and open partial nephrectomy showed improved survival for tumors less than 4 centimeters. There was another systematic review and meta-analysis by Nicola Pavin in 2017, which looked at tumors more than 4 centimeters. It looked at 13 studies comparing outcomes of partial nephrectomies. It looked at tumors less than 4 centimeters in 4,441 patients and tumors more than 4 centimeters over 1,000 patients. And it noted that warm ischemia time was shorter and the odds of peri-op complications were lower in less than 4 centimeter group. However, it saw no difference between the likelihood of positive margin between the two groups. Many attempts have been made to undertake randomized trials in small kidney tumors in UK. The first attempt was by Cancer Research UK, which commissioned CONSERVE study, which looked at undertaking 3 treatment arms of radiofrequency ablation, cryotherapy, and partial nephrectomy for small kidney tumors. The other attempt was by HTA of comparing ablation versus surveillance in small kidney tumors. Sadly, both of these feasibility trials did not accrue to the numbers expected, hence main trials were not undertaken. When you looked at the picture in UK, according to BAUS Audit 2019, 3,130 patients underwent radical nephrectomy in 2019. 75% were laparoscopic, 5% were robotic, and 19% were open. In that year, 1,562 patients underwent partial nephrectomy. 9% were laparoscopic, 76% were robotic, and 14% were open. Interestingly, in the T1A group, less than 4 centimeter, 65% underwent partial nephrectomy. However, 37% patients still had radical nephrectomy. So one can see very clearly that among the radical nephrectomy group, most of the patients are having laparoscopic radical nephrectomy, and in the partial nephrectomy group, majority of the patients are having robotic partial nephrectomy. However, 1/3 of the patients, tumors less than 4 centimeters, still go on to have the whole kidney removed in UK. In view of that uncertainty, NIHR HTA has commissioned a call of undertaking a randomized study comparing partial with total nephrectomy in clinically localized renal cell carcinoma. After this call, 2 groups were asked to submit bids for the second stage. One group was led from Royal Free. They suggested proper trial. The other group is led from Newcastle. They suggested partial trial. In partial trial, The assumption was based on these studies. It looked at a typical 65-year-old patient undergoing kidney cancer surgery to note that average pre-op GFR in this group of patients would be around 70 mils per minute. It also noted that individuals with reduced renal function, that is renal function or GFR of less than 60 mils per minute, have a 40% increased risk of cardiovascular event and 20% increase in all-cause mortality. It also noted that partial nephrectomy was associated with significant reduction in CKD and 30 to 45% reduction in mortality in patients with GFR of less than 60 mils per minute. And in case of T1A tumors with normal contralateral kidney, GFR decrease after partial nephrectomy is 9.6%, whereas after radical nephrectomy, it is 32%. So the partial trial has suggested to undertake two arms, multi-center, pragmatic superiority trial comparing partial nephrectomy with radical nephrectomy. It is focusing on trade-offs between potential benefit versus harms and cost comparison between radical and partial nephrectomy. Its primary objectives are going to be the benefits, that is preservation of renal function versus harms of surgical complication between the two groups. It would also aim to look at secondary objectives of health-related quality of life questionnaires, cost effectiveness, quality of recovery, surgical margin, cardiovascular events, and CKD. The question at the end we must ask, should we be doing partial nephrectomy just because we can do it technologically? Or should we be doing it because we believe and we can prove through a randomized trial that the harms of partial nephrectomy or possible complications are worth the price paying for the benefit of preservation of kidney function, and on the long term, that has an improved survival. We don't have an answer to that question, but I hope that after the completion of this HTA study, we will be in a position to answer that question, but we'll have to wait for at least 5 years for that answer to come before us. At the end, I'll thank again SIU for asking me to give you this perspective. Thank you very much.